We're going to talk about a very common common presentation in the pediatric emergency department, pediatric surgical department, which is a child presenting with features of intestinal obstruction. How to evaluate and what is their management. So I'm going to give you a very broad overview today. I'm not going to go into very specific details of each and every condition. Instead, I'll be giving you an overview as to how to evaluate and how to manage. So the objectives of this today's lecture would be to discuss various etiologies of intestinal obstruction in children, their diagnosis and evaluation, and also to look at management. So when you get a child with suspected or possible intestinal obstruction, there are a few questions that as clinicians we answer. The first question is this intestinal obstruction, or whether this is actually intestinal obstruction? So that means we need to confirm the diagnosis of intestinal obstruction. The second question is, once you of course confirm the diagnosis, what is the level of the obstruction? The third question is, what is the potential or possible etiology for this obstruction? The next question for a surgeon or for any clinician in that matter is, does this patient require urgent surgical intervention, or does the surgeons need to be called in immediately? If so, what is the immediate management and what is the definitive or ultimate management of this child? So those are the different topics that we are going to base our presentation or lecture on. Right, so I will be discussing intestinal obstruction in children in three different categories. The first category, and the category that I'm going to spend most amount of time today, is talking about neonates with intestinal obstruction. So neonatal intestinal obstruction. The second category is a slightly older child, an infant with intestinal obstruction. And the third category is an older child, more than 1 year, with potential intestinal obstruction. So when you talk about newborns or neonates, as clinicians, it's easy or convenient for us to categorize causes of intestinal obstruction into proximal and distal. So causes of proximal bowel obstruction are pyloric stenosis, duodenal obstruction due to duodenal atresia, malrotation with or without volvulus, proximal jejunal atresia. So they belong to the category of proximal bowel obstruction in newborns. Distal bowel obstruction can occur due to ileal atresias, colonic atresias, meconium ileus and meconium plug syndromes, hypoplastic left colon syndrome or small left colon syndrome, and Hirschsprung disease. So those are common causes of proximal as well as distal bowel obstruction in neonates. If you look at the presentation of a neonate with suspected intestinal obstruction, there are a few cardinal features. With more and more use of antenatal or fetal ultrasound scans, antenatal diagnosis or antenatal suspicion of bowel obstruction is becoming more and more common. One such classic example would be a baby or a newborn with possible duodenal atresia or duodenal obstruction, which can easily be detected antenatally. Postnatal features are bilious vomiting, abdominal distension, failure or delay in passing meconium. Those are the classic features of intestinal obstruction in newborns. When you talk about passage of meconium, we know that about 95% of all newborns pass meconium within the first 24 hours. and up to about 98% of newborns pass meconium within the first 48 hours of life. Any delay beyond that is considered abnormal. Very rarely, the newborn can present as with shock as the sole presentation, which could be due to intestinal obstruction. So, as I told you before, the three cardinal features of intestinal obstruction in newborns are bilious vomiting, abdominal distension, and failure or delay in passing meconium. So, out of which, as clinicians, it's very important to identify bilious vomiting. You'd be surprised that even today, that some of these children or newborns with intestinal obstruction has been missed. There's a very interesting publication recently in the Journal of Pediatric Surgery International, and this study was conducted by a team of researchers in the Children's Hospital in Monash, Victoria, Australia, where they have looked into the perception and knowledge of healthcare professionals regarding color of neonatal vomiting. And according to that survey, there is still a significant percentage of healthcare professionals who lack knowledge about the significance and understanding of bilious vomiting in newborns. This color chart was first published in 2006 in the British Medical Journal, where they have identified a color palette or color chart which signifies bilious vomiting or significant bilious vomiting in newborns. So according to this color palette, colors 6, 7, 8, which signifies more and more green vomiting, is considered significant, and it's very significant in terms of the pathological cause of vomiting. So any newborn who has green vomiting, who has bilious vomiting, has a significant underlying pathology and needs further evaluation. Therefore, the take-home message here is bilious vomiting or green color vomiting in a newborn is considered significant, and it certainly needs immediate surgical referral. So it's something that, as clinicians, something that we cannot miss. Right, so the first question for clinicians, anybody who is dealing with a suspected case of neonatal intestinal obstruction is this intestinal obstruction, or is this a diagnosed case of intestinal obstruction? So how do you do that? It's a clinical diagnosis based on symptoms and signs, and it's confirmed by imaging. So as I told you before, the symptoms suggestive of intestinal obstruction are classic: bilious vomiting, abdominal distension, and delay in passage of meconium. So if you have those features, then the next step would be to look for any supportive evidence from history and examination. So if you go to the history, features such as maternal diabetes mellitus might indicate a possibility of hypoplastic left colon or small left colon syndrome. A family history of intestinal obstruction in the newborn phase might indicate a rare case of familial jejuno-ileal atresias. Prematurity, you might be looking at something like necrotizing enterocolitis. So those are all clues for you to arrive at a possible etiology, which is resulting in intestinal obstruction. Next, in the examination, also there may be supportive evidence such as dysmorphic features or features suggestive of trisomy 21, which could be a baby with duodenal atresia. Absence of anus or a malpositioned anus could be a patient with anorectal malformation or imperforate anus. Rectal examination findings may be suggestive or give you a clue as to what the diagnosis is, especially in case of Hirschsprung disease. So all those features, symptoms and signs are helpful in arriving at a diagnosis of neonatal intestinal obstruction. So once you have that classic history and examination, the next step is to confirm your diagnosis by imaging. And that is achieved by means of a plain X-ray abdomen, supine. And it's a very common mistake that we see more and more amongst clinicians, that there is a reluctance to obtain a plain X-ray abdomen in a newborn. Instead, most of them resort to ultrasound scans, which is of course not a very useful or a helpful investigation in confirming the diagnosis of intestinal obstruction. Instead, all we need to do is a plain X-ray of the abdomen, supine. So with these two, with the classic history or symptoms and signs, and a suggestive plain X-ray abdomen supine, the diagnosis of intestinal obstruction will be confirmed. Once you do that, the next question for the clinician is to determine the level of obstruction. So for you to do that, all you need is the plain X-ray abdomen. And looking at that, an experienced clinician or a radiologist should be able to tell you whether it's a possible proximal bowel obstruction or a possible case of distal bowel obstruction. Now, this slide shows you two X-rays of newborns who presented with proximal bowel obstruction. And as you can see very clearly, the picture on your left-hand side shows two gas bubbles. So this is a newborn who presented with duodenal atresia with double bubble appearance. And the image on your right-hand side shows a single gastric bubble. So both of these X-rays tell you that the obstruction is quite proximal. Now, these two X-rays are classic examples of distal bowel obstruction in newborns. Compared to the previous X-rays, you can see there is a long length of bowel which is dilated on both these X-rays. So that means whatever the obstruction is quite distal. So these two X-rays are examples of distal bowel obstructions in newborns. So the first objective of a clinician is to confirm the diagnosis of intestinal obstruction with a history, examination, and a plain X-ray supine which shows dilated bowel loops and potentially absent rectal gas. So those two features are pathognomonic of intestinal obstruction. Then further information such as the length of involved bowel or length of dilated bowel will give you an indication as to whether this is a proximal bowel obstruction or a distal bowel obstruction. So that is the second question that we need to answer. The next question is, what is the most likely etiologies? So once you identify that this is a proximal or a distal bowel obstruction, and once you know the common causes of proximal and distal bowel obstruction, you know what the most likely cause or causes are going to be. So depending on what the X-ray suggests, so if the X-ray suggests it's a proximal bowel obstruction, you might need certain other investigations like an upper GI contrast study to confirm the etiology or the diagnosis. Similarly, if your X-ray shows features of distal bowel obstruction, just like in this, You might have to do certain other investigations like a rectal examination or a rectal washout, a contrast enema or a lower GI contrast, and occasionally even a rectal biopsy to arrive at the exact etiology that causes distal bowel obstruction. So let's look at some examples of proximal bowel obstruction. So as I told you before, the diagnosis of proximal bowel obstruction is made on clinical assessment as well as the plain X-ray findings. And once you do that, in certain cases, of course, if you get a classic X-ray suggestive of a duodenal atresia, which is a double bubble appearance, you might not need any more investigations because that X-ray itself is pathognomonic. But sometimes you might not know what's going on. You might only know that there is a proximal intestinal obstruction. Therefore, you might want to clarify the etiology by doing an upper GI contrast study. Okay, this is an upper GI contrast study that was done in a child newborn who presented with intestinal obstruction, and the X-ray showed evidence of proximal bowel obstruction. So one of the key differential diagnoses in a baby with proximal bowel obstruction is malrotation or midgut malrotation. And the diagnosis of midgut malrotation is important because it is a condition which has to be operated on urgently. Therefore, your exact diagnosis is very important, and the exact diagnosis is made by an upper GI contrast study. So if you focus on this contrast study, you can see that the duodenal loop comes in and the duodenojejunal flexure has begun somewhere in the middle of the vertebral column. And you can see that the jejunal loops are positioned on the right side of the abdomen. Versus in a normally rotated small intestine, you can see the duodenal loop coming in this way, crossing the midline or the spine, and the DJ flexure starting somewhere in the left of the abdomen, and the small bowel loops more towards the left side of the abdomen. So this was a case of malrotation and picked up by the contrast study because the X-ray showed possible features of upper GI or proximal bowel obstruction, and the patient or the baby presented with bilious vomiting. So let's look at another case of potential distal bowel obstruction. Similarly, the diagnosis of distal bowel obstruction is made using clinical assessment and also using the initial plain X-ray supine abdomen, which shows a large length of dilated bowel. So once you have that explanation, there can be many potential causes, starting from jejunoileal atresias, meconium ileus, meconium plug syndrome, Hirschsprung disease, hypoplastic left colon syndrome. So there can be many such causes. And the reason why we need to try and find out the exact etiology is not all of these conditions need immediate operation. Some of these conditions can be managed conservatively. Similarly, in the proximal intestinal obstruction group, most conditions will need laparotomy, but if the diagnosis is something like malrotation with volvulus, you cannot even wait for the next day. You need to operate on the baby immediately. Therefore, it's very important to get to the bottom of it and I try and identify the exact etiology. So let's try and do the same for a large bowel obstruction. So diagnosis made by clinical assessment, plain X-ray. And for you to arrive at the exact diagnosis, you might have to do certain things like a rectal examination, contrast enemas in say various cases, and even rectal biopsies. So if I were to explain this a little bit further, rectal examination will give clues in a case like Hirschsprung disease, where you know that in Hirschsprung disease, when you do a rectal examination and when you take your finger out, there is a gush of gas and liquid feces. And that itself is quite characteristic of Hirschsprung disease. On the other hand, if it's something like a meconium plug syndrome, with your rectal examination, after a while, there might be a passage of a large pellet of thick meconium. And after that, you might see that baby decompresses very well and the features of abdominal intestinal obstruction disappears. So that so rectal examination can be both diagnostic as well as therapeutic in certain cases of distal obstruction. Contrast enemas are required if you suspect a patient with Hirschsprung disease to identify the level of the disease. And even in cases like hypoplastic left colon syndrome, the contrast enema would be diagnostic as well as therapeutic. Also, in a case like meconium ileus, you might be able to see inspissated, hard, thick meconium pellets all the way down to the distal ileum, and those can be detected on contrast enemas. In a baby with suspected Hirschsprung disease, once you do the basic assessment, a rectal biopsy is required to arrive at a histological diagnosis. So that is the workup for a baby with suspected distal bowel obstruction. And this shows you an image, a contrast, a lower GI contrast image in a baby with suspected distal bowel obstruction. So this baby presented with classic features of intestinal obstruction, namely bilious vomiting, distension, and delayed passage of meconium. The next step, we took a plain X-ray of the abdomen, which showed features of distal bowel obstruction. And that was followed by a digital rectal examination, which revealed a gush of air and stools, that was pathognomonic of Hirschsprung disease. And that was followed by a lower GI contrast study, which showed this appearance. And that was, again, very characteristic of Hirschsprung disease. You can see that there is inversion of rectosigmoid ratio, which is a typical feature that you see in Hirschsprung disease. So this baby had this contrast study, and the diagnosis was confirmed by a subsequent rectal biopsy, which showed features of Hirschsprung disease. Right, so that is the basic diagnostic algorithm for a newborn presenting with intestinal obstruction. Again, if I were to recapitulate, clinically suspect the presence of intestinal obstruction by presence of bilious vomiting, abdominal distension, and delay or failure to pass meconium. That will be supplemented by a plain X-ray abdomen supine, which shows dilated bowel loops with absent rectal gas in most cases. So with those two combined, you make a diagnosis of intestinal obstruction. Then your next step is to see whether this is a proximal obstruction or a distal obstruction. That you will do by looking at the plain X-ray. So in certain cases of proximal obstruction, you might want to get an upper GI contrast study to rule out certain causes such as malrotation. Similarly, in a case of distal bowel obstruction, you might want to do rectal examinations. Contrast enemas, rarely you might want to do rectal biopsies. Okay, so with all these measures, you arrive at the diagnosis. Now, we will go through the management protocols or the principles of management in these newborns. So when you look at management, there are general management principles that can be applied across the board in all the newborns. And also there are certain disease-specific management principles. So the general principles involve keeping the baby nil by mouth, inserting an NG tube to decompress the stomach. Another important thing to remember is when you insert an NG tube or a nasogastric tube, it's very important to make sure that the NG tube is open and is connected to a drainage bag or a saline bottle or a syringe, because oftentimes we see that babies are being transferred from various hospitals with an NG tube, but the NG tube is clamped. So it does not serve the purpose, because if the transfer takes few hours, by the time the patient reaches the pediatric surgical center, the stomach could be filled with bilious aspirates, bilious secretions, and there is a very high potential that the baby might aspirate, leading to aspiration pneumonia and even death. Therefore, it's very important to put an NG tube and decompress and make sure that the NG tube is persistently draining. Intravenous fluids are very important. Some of these babies are actually, they have features of dehydration. Therefore, it's important to assess their level of hydration and administer fluids accordingly. Do not forget about hypoglycemia. Little babies are very prone. So therefore, you might have to check their sugars often. Electrolyte imbalances are also very common in these patients. So metabolic abnormalities, it's very important to pick them up and correct during fluid management. Hypothermia is another very important aspect to consider when you're, especially when you're transferring these babies across long distance to pediatric surgical centers. And all of these babies will be started on prophylactic antibiotics prior to transfer or prior to surgery. So these are principles that we employ in any baby, whether it's proximal or distal bowel obstruction, and regardless of the cause or the etiology. So next, we will look at specific causes and their specific management. So starting with proximal bowel obstruction. So supposing you get a baby with bilious vomiting who turns out to have malrotation, which was diagnosed with by the upper GI contrast study, then you know that this is a surgical emergency and that baby needs emergency laparotomy for correction. And before that, if there is any features of dehydration shock, you need to resuscitate the baby. But once you do that, the baby goes to theater for an emergency laparotomy. Next, you have causes such as duodenal or jejunal atresias. So they need, all of these babies do need laparotomy for correction, but they don't need to be rushed in the middle of the night like what you do for a baby with malrotation. Certainly you can wait for a few hours or until the next day for the laparotomy. Next, we move on to the distal bowel obstructions, specific causes. Ileal or colonic atresias, again, just like the duodenal atresias, they need laparotomy for correction, but there is no emergency surgery required. So you can investigate the child, do the basic assessment, and plan for surgery the following day. Meconium ileus is another cause of distal bowel obstruction, specifically distal small bowel obstruction. And the majority of these babies with meconium ileus have cystic fibrosis. We don't know we rarely see meconium ileus in this country, and we still don't know the percentage of those babies having cystic fibrosis. Meconium ileus can be managed both non-operatively as well as surgically. So not so severe cases can be managed just by using the contrast enema, which is used as a diagnostic test. Some babies require laparotomy if the meconium is very thick and inspissated and if it does not decompress easily. Sometimes we do a laparotomy, make a small incision in the intestine and irrigate the bowel with saline. And once the meconium pellets are removed, we just suture the small entry opening in the bowel. Severe cases of meconium ileus might need temporary ileostomy formation for a few weeks until the baby decompresses and evacuates all the inspissated meconium pellets, and then we go in and close the ileostomy. So that's about meconium ileus and distal atresias. Then there is an entity called meconium plug syndrome, where there is a thick inspissated plug of meconium blocking the left colon, mostly the descending colon and the sigmoid colon, and there is no other abnormality in these babies. So most of the time when you do a rectal examination or if you gently do a bowel wash, that meconium plug gets evacuated and the baby gets well. So you don't need to do any surgical intervention for those babies. Hirschsprung disease is a very important cause of distal bowel obstruction in newborns. It's a cause of functional obstruction. There is no structural abnormality. More or less, more than that, it's a functional abnormality which occurs because of abnormal enteric nervous system that innervates the distal bowel, namely the rectum and the sigmoid colon. That is the most common presentation, but it can involve the rest of the colon, and very rarely it can involve the entire intestine, which is incompatible with life. So if you suspect Hirschsprung disease, which is suspected by the X-rays, digital rectal examination, and once you make that suspicion, you start these babies on rectal washouts twice a day or 3 times a day to decompress their distal bowel. And once we are happy that they are decompressed washouts, before they are discharged home, we do a rectal biopsy to confirm the diagnosis of Hirschsprung disease. Once you confirm the diagnosis of Hirschsprung disease, most of these babies go home with the mothers after the mothers being trained to do rectal washouts. And they continue to do the washouts at home for about 4 to 6 months until the baby is a bit bigger. And then we plan for the definitive surgery, which is called a pull-through operation, where we remove the segment of intestine affected by Hirschsprung disease and pull through the normal intestine or the colon and anastomose it or connect it to the anal canal. So that is how we manage Hirschsprung disease. The definitive, unlike in atresias or malrotation, will not be done immediately. So once you diagnose, you will start them on rectal washouts or irrigations and a biopsy done, and the baby is discharged after that. And the definitive surgery will only be done after a few months' time. So that is an overview of common causes, evaluation, and general as well as specific management of children or newborn who present with intestinal obstruction. So let's move on to the second category, which is infants. If you look at the causes, they are more or less the same, but you won't get a patient with a complete atresia presenting as an infant, because they should have presented during the first few days of life. Instead, you can have a situation where a segment of the intestine is not completely atretic but narrow, or stenosis. Example, duodenal stenosis or ileal or colonic stenosis. They can present quite late in the infancy with features of intestinal obstruction. So apart from the causes that we discussed in the neonatal group, so things like meconium disease is uncommon in infants. Instead, you can have causes like congenital bands, duplication cysts, obstructed hernias presenting in the infant group. The one most common cause of intestinal obstruction that presents in the infant group is intussusception. The commonest age, as you already know, is around 6 months, 4 to 6 months, going up to about 9 to 10 months. It's very rare for a child to have intussusception below the age of 3 months and also older than 2 to 3 years. So roughly, you're looking at an infant who's around 6 to 10 months or 6 to 1 year, that age group, presenting with features of intestinal obstruction. So this picture is a baby who presented with intestinal obstruction to one of our hospitals, who is on the operating table being subjected to saline reduction. And you can see that there is reddish color mucoid stuff that is coming through the anus, and that is what we call red currant jelly stools or red currant jelly appearance. So intussusception, the presentation is different to the typical intestinal obstruction where you get bilious vomiting, abdominal distension, and failure to pass meconium. Instead, these infants present with colicky abdominal pain, which worsens with time. Red currant jelly stools, which is what is shown in this photo, and rarely an abdominal mass. So this is considered the triad of symptoms and signs of intussusception. But however, the important thing to note is that all these three features are only present in less than 25% of babies with intussusception. And things like red currant jelly stools is a late sign. Therefore, nowadays you might see a lot of babies who only have colicky abdominal pain, which is the most common presentation of intussusception. So if you compare the diagnostic techniques with what we discussed before, I told you the most important diagnostic test for intestinal obstruction is a plain X-ray abdomen supine. However, there are two exceptions. This is one exception. Ultrasonography or ultrasound scan of the abdomen is the diagnostic test of choice. It has a sensitivity and specificity which is close to 100% in experienced hands to diagnose intussusception. The other instance where you need an ultrasound scan for diagnosis is pyloric stenosis. So apart from those two causes of intestinal obstruction, there are no other etiologies that can be reliably diagnosed by an ultrasound scan, common etiologies. Therefore, there is no justification for the clinician to perform an ultrasound scan in neonatal or otherwise intestinal obstruction unless you suspect intussusception or a pyloric stenosis, which are two very different and distinct etiologies. So if you have a patient with intussusception, again, the management involves the general principles of intestinal obstruction, meaning nil by mouth, NG tube, IV fluids, IV antibiotics. In addition to that, the definitive treatment of intussusception is usually non-operative. So which can be either performed by a AR reduction technique or a saline reduction technique. So AR reduction is considered superior to saline reduction. However, in Sri Lanka, we do not have the facilities or the necessary equipment for an AR reduction. Therefore, we commonly perform saline or hydrostatic reduction technique, which has more or less similar success rates. For infants who fail the initial non-operative management or who have complications such as bowel perforation, will end up getting an operation or an operative technique for management of intussusception. Then again, the operative techniques can be open or opens a reduction of intussusception or a laparoscopic technique as well. Both are equally effective. However, the laparoscopic techniques have the added advantage of less pain, short hospital stay, etc. So if you want to know a little bit more about the current management of intussusception, there is a good article in which is published in Cochrane Reviews. It was conducted in 2017 by a team of physicians in Sydney Children's Hospital, where they have looked at different management options and their pros and cons when it comes to management of intussusception. So that's the unique etiology when it comes to infants, which can cause intestinal obstruction. But most of the other causes that newborns get, infants also are prone to get. So the third category of children are older children. So anybody beyond the age of 1. So supposing if you get a 9 or 10-year-old with intestinal obstruction, what would you suspect? So their etiologies are very different. You wouldn't suspect things like pyloric stenosis, duodenal atresia, etc. Of the proximal obstructions, I would say malrotation volvulus is possibly the only one that remains. So any child, any person presenting with bilious vomiting, malrotation and volvulus is a possibility. So you need to be aware of that. Of the distal obstructions, Hirschsprung disease can present at any age. In the older children, they present mostly with features of chronic constipation, with or without features of failure to thrive. Congenital bands, obstructed hernias, lymphomas, intussusception due to secondary causes like polyps or tumors can occur in this age group. Again, the management principles should follow the initial principles that we've discussed, namely fluid resuscitation, nil by mouth, NG tube, IV antibiotics. So those things will be the same regardless of the age of the child. So now we've come to the end of the presentation. So we've looked at different causes of intestinal obstruction according to 3 categories, age categories: newborns, infants, and older children. And we saw how these etiologies, some of them overlap and some of them are quite unique to different age groups. And I discussed with you the evaluation algorithm of a child with intestinal obstruction, focusing on few questions. Is it intestinal obstruction? How do you confirm? Number 2, what is the level of obstruction? Is it proximal or distal? Number 3, what is the potential etiology? So you might have to do a few other investigations. Number 4, is there a requirement for immediate surgery depending on the etiology? Number 5, what is the general management and the specific management of this patient? So that brings us to the end of today's presentation. And thank you very much for your participation.